no, this is a challenge. There's no doubt. But my point to Dr. Fuster was that once you tell somebody you're going to die in the next 12 months if you don't do anything, there might be some more psychological effect. I mean, you're saying no?
I frame it a little bit differently in the spirit of this and putting together different things I've heard. So first we're talking about primordial prevention, having good health and preserving it because your LDL stays low over a lifetime. And that's one aspect of it. What you're talking about is identifying these super high-risk people with a 50% 1 year or 2 year risk. To me, I'm a parental cardiologist. Every patient sees my nutritionist, exercise physiologist, but it's a little too late to do that alone at that point. We know that look ahead, higher risk people, lifestyle alone did not do it. So at that point, it's not sufficient in a very high-risk person where that's the only thing you're doing. And I think that's when we get creative, I think, where you, whether it's PCSK9 for 1 year or 2 years or 3 years, whether it's something, more aggressive from that perspective. So I think we're sort of talking about two different aspects. One is primordial prevention, preserving good health, lifelong preservation of low LDL. But for whatever reason, if you end up with a super high risk, if we're able to use machine learning and identify in a very short amount of time, I think lifestyle alone based on
definitely
it's not. Don't misunderstand me. I'm not saying don't do lifestyle. I think it's complementary. But similarly, you wouldn't take. I think what Dr. Fuster was saying is in freedom, these people. We didn't say don't take a statin. The data suggests they're high enough to warn it. Your 50% says this is the person who should get it, but they wouldn't put it in their mouth. Only 20% were taking the pill. And I think that's the adherence part of that. I'm not sure that if you scare someone and say, boo, they're going to put it in their mouth anymore. But their doctor at least says, this is someone who identify might not have before. So this is.
Well, I think I'm going to go back to the analogy of cancer. David, you go ahead first.
Okay. Well, you might be sort of rambling, but I'll get there. So, is it valuable? Would it be valuable to be able to identify someone at such high risk that we could predict a 50% chance in the next year that they're going to die? And I think that would be a good contribution. I think that would be useful. Would it really change how we practice? And I think the example of somebody hospitalized for an acute coronary syndrome who within a year has a 50% chance of still being on a statin, who I don't know what the statistics are for a smoker to stay abstinent, but the statistics are pretty crappy for somebody who has been told with a symptom that they have a very high percent chance of dying within the next year.
But that's not as more than 10, 15% now. We put them on, aggressive therapy after the event. And my point was that trying to bring this primary prevention close to cancer and what we do in cancer, once you find somebody with tumor and the survival for 12 months is 50% and so on, you cause some action. Now, if what Amit said, if the treatment is all about what they do, lifestyle change, obviously it's not enough. But if we develop new interventions, like what Dr. Brownwell says, if it is more than 25% or if it's 50%, it justifies a bypass, then I think we can make a difference because now we have new tools that we could not use before. And so that's the point. And obviously we have to have trials for those. And because it's such a short time, by definition, such a short term, we should be able to do a lot of trials because it only takes 6 months or a year to see the outcome. If, that it all comes back to these computer guys to develop that 25% and 50% machine learning algorithm. But once developed, the question is what we're going to do,